thank you guys so much for coming out. I was very nervous about talking to people, but then with so many familiar faces in the audience, I feel much better. Okay, so first I want to give a couple of disclaimers. Number one is I have worked a lot with patients who have been addicted to drugs and alcohol throughout the last 20 years, but I certainly wouldn't put myself forward as an expert in the topic, but I would like to share some of my experiences and some of the things that I find helpful for my patients. I would also like to set as a disclaimer that a drug and alcohol addiction isn't strictly the topic of what we're going to talk about tonight. It's really more alcohol and opiates, because those are really the only areas that we as physicians have, medicines for, and that's our specialty, is prescribing medicines. So in terms of something that we can treat from a medical perspective, opiate addiction and alcohol is kind of, to some extent, it. Methamphetamines are a super huge problem in our community, but we don't have a good fix for that. That's a much more complicated topic. Marijuana, for people who are trying to quit marijuana, people who maybe are addicted to anxiety medicine like Valium, Librium, we don't have really good answers for some of those problems. So I'm going to kind of devote myself to the things that I know I can sometimes get in there and fiddle with and try to help people with, and that's alcohol and opiates. So do you guys know what I mean when I talk about opiates? What do I mean? Heroin, oxy, so all of the pain pills, right, like methadone, Percocet, MS-Contin. As you guys know, that's become a super huge problem right now across the country. There is more people dying of opiate overdose in this country than die from car crashes now, and it's been rising steadily for the last 10 to 20 years. So it's definitely a topic that's near and dear to my heart. A third disclaimer is, whenever I see a medical presentation, they always have to talk about personal prejudices or, I'm funded by Novartis and I need you to know that. So my personal investment in the kind of one of the reasons I wanted to give this talk is because Dr. Glyer and I are running a Suboxone program at Adventist Health Howard Memorial. And we're really, really excited about it. And we're really, really excited about the use of Suboxone in general for opiate addiction. And so I'm going to save that part till last, but I definitely have a personal prejudice in that area, so I'm going to disclaim that freely at this time. And final disclaimer is I definitely want to acknowledge that pharmaceuticals, in any kind of medical disease, and definitely in this disease, is a small, small piece of the pie, right? As you guys can imagine, somebody coming from a perspective of opiate addiction or alcohol addiction, like actually getting to the doctor to the point where you're able to talk about that, you've already probably done 60-75% of the work that you had to do to get there. So anything that I do in the office is going to be just a small piece of whatever that person's personal journey of rehabilitation is going to be. So I'm kind of curious if any of you guys have any thoughts about things that you think, non-pharmaceutical interventions that you know of that other people have tried or that you've tried if you had, say, an addiction to food or whatever, things that you have found helpful in terms of treating addiction or treating a problem like that. Sir?
Definitely say the 12-step programs, whatever they are, AA, NA, have been shown to be quite effective as some treatment.
Ding, 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 ding. Yes, I'm definitely also super prejudiced in terms of NA and AA. In order to just take a moment to talk about that, I think, to me, it seems like a really, really big piece of battling addiction is to be able to be honest with yourself about it, and then a part of that is being able to be honest with other people about it. And so the people that I've seen that have had the most success in recovery are the people that can openly talk about it with almost anyone. And so when somebody comes to me, and I'm not saying this is a hard and fast rule, but when somebody comes to me and say that they're interested in recovery, and I mention NA or AA, and they're like, well, those people, I don't have anything in common with them, or, it's hard for me to get there, or they're just dealing drugs at those programs, or, there's a lot of reasons why people are hesitant to go to them, and I'm always a little bit crestfallen and concerned that maybe it's going to be really hard for this person to get clean, because I feel like they're not able to stand up in front of somebody else and say, this is a problem that I have, and I think that really makes it harder. And I'm sure you know this in life. If you're in a marriage and there's something that you two aren't talking about, and it's just festering and festering, and you can't come clean and you can't talk about it, then you're never going to move past it to resolve the issue. So I think that NA and AA, to me, it seems like for nothing else but that, being able to be honest with other people is super critical for success. Yes.
My cousin quit coke by taking the pilgrimage from northern Spain, northern France, all the way to Spain.
He walked the what?
He walked for 10,000 or 2,000 kilometers through France and Spain. It's a pilgrimage that many Europeans and people around the world do. I work with people in this field, looking at people's cultural backgrounds. Hispanic and Native American cultures have lots of different religious and ceremonies that they can use that you don't really typically tend to recognize as Western practitioners and people who are caring for people. So for me, really looking at those cultural practices is a very important piece of what we're talking about here.
Absolutely. There's the cultural piece of it. I think that's really important. The Camino de Santiago. And I think there's the cultural part of it. I think you're right, is really important, and there might be some culturally specific, routines or rituals that could be helpful. And then I think what you're talking about with the Camino de Santiago, that personal level of commitment, like I can do something really, really hard. If I could do this, I can do anything. It reminds me of that book about the lady that walked the trail. What's the Pacific Crest Trail Wild, right, to get off drugs. So, yes.
Yeah, from my experience, one of the things that's kind of at the root of opiate addiction or alcohol addiction or others is that there's some pain that you're suffering in your life, and in one level, opiates are a painkiller, and they are not solving the problem, but people, I think, are trying to deal with pain.
So you're talking about like emotional and, yeah.
So anything that helps people both get in touch with the pain and be able to address the pain. And in some ways, the core pain, I think, is our disconnection from ourselves, from each other. And so programs like AA and NA and some of the programs you're talking about, one of the core things they do is reconnect people with each other, with themselves. And I think programs that do that are able to be effective in both treating the internal pain and treating the underlying cause of the addiction.
Absolutely. So maybe to dovetail to that, therapies for people who maybe don't want to go to a meeting, or in addition to meetings, therapy to get at some of the emotional pain that started the whole problem in the first place, or to deal with things that might trigger them to set off in the future. Absolutely. I worked for a short time at a marijuana prescription place, doctor's office, and I would have patients who, had Hep C and were trying to avoid going back to IV drug use, or were trying to quit alcohol, so that was kind of back before the CBD thing got really big. It was just marijuana, but they found medical marijuana helpful for those things, definitely. And I think maybe from an NA perspective, they talk about being drug-free, period, and so I think that that's a good way to go for some people. I think that some people are going to take a road of moderation, maybe somewhere in the middle, not completely, absolving themselves of any need for drugs whatsoever. I feel like anybody who is in recovery feels like this is not something that, they've shut the door on, that there's always the potential for relapse. The emotional pain that Judd was talking about is, could be around the corner anytime, and all of those predilections that we have that lead us to addiction in the first place are all still going to be there. So, and once you've walked that road, it's very easy to go back to it, absolutely, and as everyone I know talks about. And so, that's a tricky question, because then sometimes I have people who, are abstinent from alcohol, and they say, well, I'll have a couple of drinks a month, and I feel like I'm fine. And, people are going to do it the way they do it, but that, of course, makes me worried, because I think that too often I've seen people who've taken that approach, like I'm going to just use in moderation, and then I'm going to be fine, and then next thing you know, they're right back where they started, and they got to start all over again. So, I don't want to tell people that that's completely verboten, but it doesn't seem to work out for everybody. to try to use in moderation any of these things that people have trouble with. I'd like to try to address since I'm a doctor, some of the biochemical reasons why people become addicted. And I think we've talked a lot about some of the non-biochemical reasons why people become addicted. But before I talk about that, I did just want to talk a little bit about the whole philosophy of happiness. And some of you guys have mentioned some of this too. The way I try to think about the interaction of the brain and addiction or any kind of problem that you have, be it, sex addiction or gambling or whatever, is that in our lives, something wonderful happens to us. We meet somebody we fall in love with, or, you're watching a woman with her baby, or you're looking at the sunset and you release those serotonin or dopamine or whatever happiness type of biochemicals in your brain, right? And then something terrible happens to you and you have a dip in all those happiness chemicals in your brain and you feel terrible and you want to kill yourself or die or suffer or whatever. And so as humans, we have this instinct to try to control that process, right? And we feel like we can do a better job of making ourselves permanently happy than Mother Nature can. And so we feel like we got to step in and take control of the situation and kind of make ourselves happy and guarantee our happiness. And I think to maybe to some extent, that's a little bit of what happens with alcohol and drug addiction. Is we're trying to replace that natural high and low that you get just going through life with a little bit of a permanent high. And so I feel like it to some extent, maybe the philosophy of letting go of that feeling of trying to control when we're going to be happy and when we're going to be sad and try to avoid suffering and try to only have happiness is part of what gets us into trouble in the first place.
Man, I haven't been around a lot of addicts and alcoholics, and I don't really see them being happy with this thing that you're saying, they're getting this dopamine high. They don't look very happy to me.
That's a very good point. Yes. I think it starts off like that. I think when you first start using something, it triggers those, and we were going to talk about that in a second, it triggers those happiness chemicals, and so it's great. But then, because, like I said, I think partly because we're trying to take control of it and our brain isn't made to work that way, then, it just leads us down the road to perdition. So how does that happen? Well, I don't know if you guys will find this interesting, but I think it's really interesting. How does alcohol affect the brain, for example? So we have our GABA receptors, right, in the brain, and we have glutamate receptors. The glutamate, if your brain releases glutamate, it stimulates you. And so you get activated, energized, going out and doing things. The GABA depresses you and kind of makes you feel chill and mellow and relaxed and sleepy or whatever. So the alcohol, when we drink it, it activates these and starts increasing the GABA activity and depresses the glutamate. So you don't have that much glutamate running around. But, like I said, the brain tries to maintain homeostasis. You guys know homeostasis, right? Does anybody not know what homeostasis means? Homeostasis is kind of how the body always tries to maintain everything in equilibrium. And so it comes out of the chute and it's got a program of how it's supposed to work. And then if we start throwing the chemicals off balance, it tries to get back to where it was before. It tries to get back into balance. So when you're when you're activating a lot of GABA receptors with alcohol and depressing the glutamate receptors with alcohol, the brain responds by making a ton more glutamate receptors. Right? It's like, hey, there's not enough glutamate around. What happened? Let's make some more. And it decreases, can't write. And it decreases the amount of GABA that you have running around. And so then this is how tolerance starts. You've had your first drink and you felt great, but now you've got more glutamate. So now you have to have 2 drinks in order to suppress all the glutamate in your brain and activate all the GABA receptors. Now you need 2 drinks. And then you make more, and now you need 3 drinks to have the same effect. So that's tolerance, of course. And then withdrawal is the process of, now I've gotten rid of all my alcohol, so I've got all these exposed glutamate receptors out there, and they are not very happy. And so that causes agitation, excitement, overstimulation of the brain, and you've got no GABA around to depress it because your body turned off all the GABA receptors because there was too much of that going on. So in the process of trying to maintain homeostasis, you and your brain are kind of at opposite ends, and that's what triggers the first tolerance and then withdrawal. And that's what you're talking about, is after the brain has started compensating for what you're doing. Once your brain's compensating, it's no longer a question of trying to be happy anymore. It's just a question of trying to get back to normal. And you're constantly trying to play catch up, and you're constantly behind because Mother Nature is much, much, much smarter than we are. So that's the process with alcohol, or part of the process with alcohol. What's the process with opiates? Wait, where's my cards?
Quick question there.
No questions. Sorry, just kidding.
I know someone that drinks and they don't drink. When they're not drinking, they're a happy, perfectly fine person, and when they drink, they're not. So that didn't make sense in that situation for me. So because I
That is a very complicated question that I can't totally answer. I do know that they talk about like different types of alcoholics, and they think that some people have a natural serotonin deficiency, and that's what they're when they're drinking the alcohol, it's increasing the serotonin, and so some of it might be, the person's kind of native chemical brain state, and that might account for partly why the alcohol affects them that way, but I don't really know.
No, what do you say when he's
just
drinking?
Just erratic, weird, just all the different things that come with alcohol. But when sober, no problems.
Oh yeah, so he hasn't probably gotten to a point of tolerance and addiction, and that point is very different for different people. Some people could drink. Yeah, some people could drink, 4/5 a day and then quit, and they don't have, shakes or seizures or anything. And then other people who drink far less, could be in the ICU. So it's kind of hard. So if you're not having any agitation or nervousness or anxiety or trouble sleeping or irritability when you quit drinking, then you're just not at that point yet, which is great. So what are the effects that the opiates have on the brain? All of these things are kind of mediated through the midbrain, the very primitive part of our brain, the lizard brain, right? And so that's why so much of this happens on a subconscious level that we don't totally understand. So this is also true for opiates. The opiates, you guys have heard of mu receptors? So the opiates attach to the mu receptor here in the midbrain, and that releases noradrenaline somewhere in a different part of the brain. And noradrenaline, that sounds just like adrenaline, right? It's an activating chemical. It's like, argh! But when the opiates bind to the mu receptor, they kind of shut this down, so you don't have as much adrenaline or noradrenaline in your brain. And so that's why when people take opiates, they're kind of relaxed and maybe a little bit sleepy and chilled out and mellow. Obviously, when you take too much of that, it goes to the level of not breathing and death. So that's how opiates kind of suppress the noradrenaline in our system and make us chill and quiet. It also, of course, creates dopamine. And as I referred to earlier, or alluded to earlier, the dopamine is one of the happiness chemicals that makes you feel happy and satisfied. And so when you first, and some people, of course, they don't start off this way. They don't start off taking it for happiness. A lot of people start off taking opiates for, I fractured my femur, I had appendicitis. So you're not necessarily taking it for dopamine, but the dopamine pathway still exists, so that you start to, if you take that pill for long enough, when you come off of the pill, you're going to feel a crash in your dopamine, you're going to feel a crash in your serotonin, you're going to feel uncomfortable, and you're like, something's not right, I need another pain pill. So that's one of the reasons that I talk to my patients about how I think that once you've been taking pain pills for long enough, the difference between withdrawal and the pain pills wearing off and I'm in my normal pain becomes really fuzzy, And so for anyone who's been on pain pills, I think for longer than a month or 2 months, once you stop taking the pill, it's not necessarily that your regular pain is coming back. It could just be that your brain says, hey, buddy, we need more Percocet. So, that's a very fuzzy line that it's hard to It's hard to know for a certain patient if they're in withdrawal or if they're in pain. But part of that problem is that just like we saw with the alcohol, you increase your receptors and you start needing more and more to get the same comfort level. The same thing is true with opiates, that you need more and more pain pills to achieve the same comfort level to a large extent. And so what that means is that it used to be that I had 6 out of 10 pain with no pills whatsoever. And now, a year later, I'm taking 4 Percocet a day and my pain level is 6 out of 10 all the time. You know, because your body has completely adjusted to that amount of the neurochemicals in your brain. And so, you know, I tell people, I'm like, it's going to be uncomfortable for you to stop pain pills, but if you're able to do it, I'm pretty dang sure that you're going to have the same amount of pain 2 months from now that you have right now, but you're not going to have to see me every month for a pain medication refill. Not only that, but I don't know if this is a good place to bring it up, but I don't know if you know this, but the majority of people starting heroin these days, do you know why they're starting heroin? Back in the 70s, it was like about, you know, tune in, what is it? Tune in, whatever. That. But now it's not that. Now the vast majority of people who are starting heroin are doing it because their Percocet is too expensive to buy anymore. They can't get enough from their doctor to maintain their level. So the vast majority of heroin addicts now started off as pain pill addicts, which is our fault. I mean, that's totally the medical community's fault. And of course, the brain, when you have this dopamine high or this noradrenaline chill out, it's very good at associating that feeling with that particular environment that you're in when you're doing that, right? So if you go over Joe's house and you use heroin or you take Percocet or whatever, and you feel good, your brain is going to remember that Joe's house is the place where you felt good, which means that if you do, say, try to quit and not take pain pills anymore, anytime you go to Joe's house, your brain's going to be like, hey! So there's very, very strong environmental cues, or maybe certain situations where people would use are going to trigger them to want to use places. Yes, ma'am?
When you said medical community's fault in that, did we know that those opiates would have that effect? Were we aware of those receptors? And the effect of that addiction that would come from that? Or is that just something that we've just really become more aware of, that we have this?
Who's we?
We, people.
I'm just kidding. Okay, we were probably under-treating pain there for a long time. I think that doctors were really kind of tight with the pain medicine for a long time. So between a combination of trying to address that and also the pharmaceutical companies trying to market certain medications, I don't know if the pharmaceutical companies, they said that the medications were non-addicting when they started pushing it. I think the first one was that really got the market was OxyContin, I think was where it really started. And so did the pharmaceutical company know that they were creating a Pandora's box? I don't know. I mean, I'm really bad at always believing what I'm told. You know, if I go to a lecture and the lecturer tells me, no, you should definitely give this out, you know, if you use it only for pain, and that's what they said, if you're using it for pain, not for fun, you're not going to get addicted. And so I think we all believe that. They're still doing it. You know, they're still aggressively marketing opiates. I can't remember what the last one was, that the FDA, they had a panel of experts. Every single one, I think, of the panel of experts recommended against approval of this new opiate medication, but it was approved anyway. So, yeah.
So what happened to the drugs that we used to take for pain that you didn't get addicted to?
Like, what do you mean? But what do you mean the medications that we used to take?
Well, like Percocet, but not the Percocet ones. But the ones that
They're all the same. They're all the same.
And how come there wasn't
The long-acting ones are more addicting, but
like the dentist used to give you those little pain pills. Darvon. They and no, I didn't. It didn't seem to do that. Yeah, so why?
yes, I think.
So the doctors prescribed them more.
And they might have given you a smaller quantity, or there might, and I think some of it could be cultural too, you know. I personally believe that 20, 30 years ago, there was an expectation that you were going to have a certain level of pain in some circumstances, you know. And I think that now culturally, just like we can't survive suffering, we can't, you know, tolerate, pain, and it's, you know, against the law to have any pain. I think a small amount of it is cultural, but any of the opiates are addicting in this way that we're talking about. over the long term, this is, I think, true of opiates and alcohol, the addiction and the changes in your brain that happen affect learning, they affect judgment, they affect decision making, and they affect memory, and possibly, lots and lots of other brain functions. Another long-term effect of the opiates and alcohol that they think it releases more cortisol. Do you guys know cortisol? It's like a steroid that your body naturally makes, and it increases your response to stress. So the feeling is when you have addiction that you've got this heightened response level to stress. And so what do you do when you're addicted and you're stressed? Well, you take more of whatever you need, of your alcohol or your Percocet to get you through. So that's another way that it kind of perpetuates the whole problem. But what, so there's the biochemistry of it, and that's always really important to me as a doctor. But of course, there's tons of, like I said, there's tons of treatments for addiction, and there's tons of reasons why people become addicted. We have talked a little bit about the emotional pain that triggers addiction. It's definitely known that a history of abuse is going to increase your chances of getting addicted. Personal stressors can increase your chances of becoming addicted. I think there's a little bit of a myth, it's not a total myth, but it's a little bit of a myth about the addictive personality, right? I have a patient come in and I'm going to prescribe them a pain pill, and I'm like, you got to be careful with this because it's addicting. And they're like, no, that's okay. I don't have an addictive personality. I don't really think it works that way. Certainly genetics plays a role, right? I think that some people, do probably have a different brain chemistry that predisposes them to addiction, but it's much, much, much bigger than that. I think, and I'm sure you guys feel this way too, that what separates us from somebody who is addicted to heroin or alcohol is, that much. You just need 2 or 3 of the right kinds of stressors to hit you in a row, or, grow up with the right kinds of parents or the wrong kinds of parents, whatever it is. And I think that that's going to put us right there with somebody who has a problem with addiction. So although addictive personality is probably true to some sense, it is definitely not the whole picture. And I think that is important for people to remember. Yes, ma'am?
I was just going to ask you, you're saying it in the negative, but I was just wondering, I mostly work with people who say, I do have an addictive personality, and so I'm just wondering, what do you say to that when somebody is saying I do? Is it still the same answer, or that you just gave essentially, or?
Okay. That's a fair point. I think, yes, I think it's true that maybe some people do turn to a thing, like I said, in times of stress or in times of trouble, they might turn to a thing more easily than somebody else. And maybe some of that is genetics. I think also some of that could be, your environment, right? Like I said, if you learned from your dad came home and he was stressed out from work and he had a drink to calm down, then you learn that from him. I think if you have a really supportive family or supportive community or supportive friends, I think it makes you less likely probably to use. Yes, ma'am?
Yeah, we're finally hearing the terms like epigenetics, where someone will say, oh, well, my parents had this, so I inherited that. Now, I love hearing finally, because it's so much more hopeful and positive, that we're not doomed by our parents. We're
Right.
little monkeys, and we watch them eat these certain things, and we eat those. But that doesn't mean we're genetically predisposed to it. We're
Absolutely.
finally breaking out of that
Right.
and seeing that our habits, like some people, if they can catch themselves and they get themselves into a habit, say, of exercising rather than turning to alcohol,
Right.
that same person can do that.
Right.
And overcome
You can learn
that.
new traits.
Yeah, new habits.
And it can be true, because definitely twin studies show that there is a genetic link, with drug or alcohol abuse. There's definitely a genetic link. So to some extent it is true. But yes, like you said, if you have an addictive personality, can you substitute this addiction with a different addiction that's not going to mess you up quite so much? Oh, do you guys want to talk about what the opiates and alcohol do to people? Or do you feel like you're all kind of understand that pretty much? The dangerous health consequences of drug and alcohol abuse. Shoot out what you know. Alcohol. Opiates. That can be liver cancer. Also probably esophageal, and I think like a lot of the upper airway stuff. So we'll just say cancer. Good enough. Yes. Nice. Yeah, that goes along with the impaired judgment, kind of. I'm going to call it MVA. And blood pressure, I'm going to call that HTN because it's shorter. Ulcers. Perforated ulcers. Kill brain cells. Oh, yeah. Violence. Yeah, I'm going to say violence, but anger's part of that, yes. Oh, like dementia and stuff like that. People are off balance. They get dementia. They get this really interesting kind of dementia where they just make stuff up. Like they just, I don't even know that they're making stuff up, but they're kind of filling in the blanks in their memory and just like saying stuff that doesn't have anything to do. What did we just say? So we're going to say dementia. All right, so that's good for alcohol. What about opiates? I mean, the biggest problem with the opiates is either overdose or the IV, the effects of IV, right? So the pain pills don't really have the IV part of it, but the overdose is huge. IV, you can get abscesses, right, from injecting. You can get an infection in your heart, which spreads to the whole body, causes your heart valve to flop open, can kill you. Hepatitis. See, really, mostly. HIV. They say that if you use IV more than, I forget what they say, like 4 times or 10 times, you're probably going to have hepatitis C. It's really, really catchy. I mean, some people are really, really clean with their needles and really rigorous about it, so they don't they can use it for a long time. But for the most part, your average Joe is going to get hepatitis C very early into their IV use.
Weight loss, a lot of
Oh, yeah. That's another thing that I forgot to mention is because you're stimulating these because you're stimulating the pleasure centers in your brain, and your brain is trying to compensate and maintain homeostasis by dampening down that pleasure, it also decreases your ability to get pleasure from other things like people, your children, sex, food. So, relationships. Oh, yeah. Acute poisoning, yes. Now, the more addicted you are, but you can get acute hepatitis, so yeah. But acute alcohol poisoning is a little bit less common because you've got such tolerance, at a certain point, you're kind of a little bit less likely to get alcohol poisoning. Okay. It's pretty good.
You could put down judgment issues as well.
Oh, heck yeah. And like I said, that is part of the permanent effects on the brain.
I was just curious, could anybody find anything good about taking any of this stuff? There's not a good list.
Good break your leg, opiates are awesome.
Pain, yeah, if you're in pain,
Yeah.
I guess you gotta take it.
Oh, yeah.
Yes, I mean, because I remember hearing about, back in the 1800s, they were talking about, this kid getting operated on for appendicitis. They didn't have anesthesia, they didn't have pain medicine, they just cut you open and took it out. Okay, so these are all the terrible things that happens when we use. So these are some of the reasons why we want to quit, right? But what are the consequences of quitting? What are the consequences? What do you think that withdrawal is life-threatening? Is withdrawal life-threatening? From what? From alcohol. You can die from alcohol withdrawal. You feel like you're going to die from opiate withdrawal, but it's very unlikely that you're actually going to die. I did have a patient in the ER in Fort Bragg who would come in like every few months having a heart attack because he'd run out of his pain pills. And every time he ran out of his pain pills, he'd have a heart attack. Yeah, it was kind of intense, but that's the only time I've ever seen something like that from opiate withdrawal. It feels terrible. What are some of the symptoms of opiate withdrawal? Huh? Irritable, nausea, vomiting, diarrhea, maybe shaky, restless, can't sleep. You're kind of activated. Remember how the noradrenaline, you're suppressing that noradrenaline and you're like, So now it's the opposite of that, which is like restless, can't sleep, depressed. Now, so some of these are more acute and some of these are more long-term. There's the acute withdrawal from opiates and alcohol, and then there's the chronic withdrawal. And the chronic withdrawal symptoms are like depression, anxiety, impaired judgment, trouble with your sleep, feeling moody. And so the acute withdrawal generally peaks at about 3 days for alcohol and opiates and can last for a week or two, maybe longer if you're withdrawing from methadone. But after a few weeks, you're through the physical part of it. But the mental part of the chronic withdrawal is really long-lasting. And that's, of course, a big reason why, like I said, we've got we've got medicines that can help people through the withdrawal process. But you need a lot more than that if you're going to go the distance because of all these terrible feelings.
If you give them a drug that makes these symptoms less.
Yes.
And they don't get addicted to that drug.
Well, let's go there. And the symptoms of alcohol withdrawal, like I said, it can be life-threatening, seizures at the most extreme. So it's hard to know who's going to go through severe alcohol withdrawal and who's just going to feel a little shaky and then feel better in a week or two. But it can be life-threatening. That's one reason why people go to inpatient rehab is to try to not die by stopping drinking. In terms of alcohol withdrawal, because of that really dangerous element to it, if somebody comes to me and they're really serious about quitting drinking, I will generally recommend a benzodiazepine taper, right? So that's the first part of trying to medicate somebody from alcohol withdrawal. So that could be Valium, it could be Librium, it could be Ativan. And so this is definitely a case where you're just switching one addicting drug for another. But in this case, because the stakes are so high, we feel like it's worth it. So if somebody comes to me, and they're really, really serious about quitting, I'll give them a taper. I'll say, okay, take one every 6 hours for the first 3 days and take 1 3 times a day for the next 3 days and go down like that. I try to definitely give it to them if they have a responsible, loving person in the room, so that the responsible, loving person in the room is the one who medicates them, because if you combine the alcohol and the benzos at the same time, that's when people die, because it's just too much suppression and you might stop breathing and die. So I generally try to have somebody on board who's helping me out with it. I tell people, I'm not going to be doing this every month for you, so you got to wait till you're ready and make it count. But it really is very good at taking the edge off in terms of being unable to sleep, preventing seizures, stuff like that. Because it's really like it's a tit for tat. You're taking the alcohol out of the system and replacing it with a benzo and then going down slowly. And there's going to definitely be an element of discomfort, It's not going to magically take away all the suffering because you're going down on the dose as you go. But I shoot for 7 to 10 days, but you try to get out of there as fast as you can. So the benzos are a key part. Certainly people can quit alcohol without them, but it takes away some of the dangerousness of it. Another one that is used, you guys have heard of antabuse? So it takes a lot of motivation, right? Because you're going to take your pill and you know that if you drink alcohol after taking your pill, you're going to get nauseated and palpitations and sweating, and you're going to feel horrible, like the flu, I guess, really bad. So, but it's good for people who are highly motivated to quit drinking. Some people can really make that work. It's good if you're, say you're going to be going out to a bar or to a wedding or something with your friends and there's going to be alcohol. You can pre-treat yourself by taking the antabuse before you go, and that way you're going to feel horrible if you drink. It's kind of like, sometimes when people want to quit smoking and they ask for the patch, you give them the patch and you're like, if you have a cigarette while you're on the patch, your brain's going to explode and you're going to end up in the ER. And you scare people so that then they don't use it. Another option that we sometimes use, and we probably don't use any of these enough. I mean, I know I don't. Naltrexone is another one that is used, which blocks the pleasurable feeling that you get from drinking alcohol. So then if you take the naltrexone, and it's pretty safe, it has rare side effect of liver damage, pretty rare, but it could happen. But people might take it for months on end or a month or two just to try to get in a good habit of not drinking, but it blocks that the alcohol from having that pleasurable effect on you. So you drink and you don't feel great. And so it tends to not have 100% effectiveness, but it does seem to keep people from binge drinking or drinking as much as they were drinking. It started off for opioids, but the stuff that I was reading says it might be a little bit more effective in the alcohol. But you have to be off of the alcohol for several days before you take it. Obviously with the end abuse too, you have to be clean from alcohol for 4 or 5 days before you start either of these. It comes in an injection form, which I think lasts like a whole month, so you can get an injection for a whole month. It comes in pill form. Blah. There's another one that I've never used, but I read about it. Nalmefene also seems to cut down a little bit on how much you're going to drink. You take it before you're going to be in a situation where you might be triggered to drink. A camprosate is good for part of the, a lot of it is good for the acute withdrawal. It decreases the physical and the emotional suffering from acute withdrawal. It increases your GABA and decreases your glutamate, which is exactly what the alcohol does in your brain. So kind of like the benzos, it's replacing a little bit of that biochemical change that your alcohol gave you. It's 2 pills 3 times a day, so it's kind of a little hard to be compliant with that for some people. And again, you have to have quit before you started. Gabapentin is an anti-seizure drug that probably decreases the moodiness and the lack of sleep. So some people might take that to take the edge off. And topiramate is another seizure drug that seems to reduces the cravings. Opiate withdrawal meds. So this is where we get to my favorite, but we're going to start with my non-favorites. You asked about naltrexone for opiates. Yes, this is where it started. It's an opiate-like drug, and I don't know that much about it either. But it's used a fair bit for opiate, not to get you through the actual physical withdrawal part, but to cut down the cravings. And I know you guys have heard of methadone, right? So we're getting there. I just want to talk a little bit in case people don't know anything about this. Methadone used to be the go-to for opiate addiction to try to keep people clean. It's an opiate, so again, you're replacing one drug for another, but it's very long-acting. So the way that it works and makes people able to kind of re-enter the job force and re-enter their families is because instead of having to go use every 2 to 4 hours, stealing money or, being unable to show up at work, you take your pill every morning and then you're more or less functional for the rest of the day. So that's how it worked, and that's why it was so successful. Problems with methadone. You have to be in a methadone clinic to get it. You have to show up. Most of them will make you show up every single day for your dose. So if you're going on a short trip, they might give you a few, but other than that, you have to show up every single morning for your dose, and that really hampers people's lifestyle. It's sedating. It's an opiate. It's just like the Percocet. So people are like a little hey, I'm feeling a lot better now. So those are some of the problems with methadone, but it's very, very successful for people who get into a program. There are no programs in Mendocino County, so it's kind of a moot point. Clonidine is a blood pressure pill that has been found to decrease cravings, but it lowers your blood pressure. Lofexidine, I didn't know this, but I learned it for this talk. Lofexidine is kind of like a similar drug to clonidine, but without affecting your blood pressure. It doesn't help so much with the cravings, but it decreases your physical withdrawal symptoms from the opiates. it also suppresses your adrenaline levels, so you're not like jazzed up and anxious. Okay, so now we get to my favorite, Suboxone. So this is partly one of the reasons I wanted to talk to you guys about opiates and withdrawal, is because, like I said, Dr. Glyer and I are we're in the middle of Suboxone program at the clinic. Law's Clinic in Ukiah has a Suboxone program. Little Lake has a Suboxone program. There are probably other people who prescribe Suboxone. Long Valley has a Suboxone program. It's another case of replacing a drug with a drug, but we really love it. Of course, doctors get really excited about things and then 10 years down the line find that it causes cancer or something, but let's just pretend like that's not going to happen. So there's a few things about it. One of the reasons that we like it is, let's say that this is Percocet binding to the natural opioid receptors in your brain. Okay, it fits really nice, right? Perfect. It activates that receptor and does all the good things that that receptor does. So Suboxone basically fills up the receptor and blocks it so that nothing else can get in. So if you took Suboxone and then you shot up with heroin an hour later, you would feel absolutely nothing because your receptors are blocked by the Suboxone. But you see how it doesn't kind of go in and fit nice and neat inside that receptor? It doesn't really it just blocks the receptor. The receptor thinks that it's occupied, it's happy, it's quiet. It's not making you go through withdrawal, but it's not, activating the receptor so that you get high or so that you're overly relaxed or so you're sedated. So you kind of basically look like a normal person and you're walking around like a normal person. And the third thing that's very good about it is that it doesn't create that chasing your tail phenomenon of increased tolerance where you have to take more and more and more. If you take 8 milligrams a day, you can take 8 milligrams a day for the next 30 years and you will be equally fine for that whole time. Like we were saying about kind of making more activity, like higher activity of noradrenaline to try to make up for the pills that you're taking, I guess it just doesn't cause that increased noradrenaline activity because it's not overly activating the receptor. So to be precise, Suboxone is a mixture of two medicines. It's I'm not going to spell it right. Okay, maybe I'll spell it right. Buprenorphine is this. This is buprenorphine. It also has naltrexone in it. The naltrexone is in there just to prevent people crushing it up and injecting it. Naltrexone is Narcan. That's what you give people if they're overdosed and not breathing. So if you crush up Suboxone and inject it, then you'll go into instant withdrawal and feel horrible. It's to decrease diversion. Our personal philosophy is if people are selling their Suboxone on the street, it's maybe not the end of the world because, it is so hard to get people into treatment, right? And there are so many barriers for people to try to get into treatment. So I think if people are in opiate withdrawal or heroin withdrawal and they have Suboxone and then they can feel normal for 24 hours, even if they go back to using, there's that taste of normalcy. And so maybe it can try to attract more people into recovery. So, if people are selling my Suboxone tabs on the street, I feel like it's probably not the end of the world because that's the fourth thing about it. You cannot overdose. Okay, it's extremely difficult to overdose on Suboxone. We try to avoid combining it with relaxants like Valium or alcohol because that could hypothetically, but you'd have to try really hard to overdose on Suboxone. So that's another great thing about it. So just to try to bring the idea home, there was one of the original articles about Suboxone use in Lancet. They took a bunch of heroin addicts and they divided them into ones that just got therapy, intensive psychotherapy for a year, but no medication, and ones that got Suboxone and intensive psychotherapy. Out of the group that were not medicated, at 1 year, 0% of them were clean and 20% of them were dead. Out of the buprenorphine group, 75% of them were clean and 0% of them were dead at a year. So, that's kind of why I'm shouting it from the rooftops, right? Because the epidemic is so bad. I have, my nephew married a woman who was she worked in morgues in Pittsburgh. She said they ran out of room in the morgues to put all the overdose victims. They had to start putting them in containers, in storage containers, because there was no more room in the morgues because so many people were overdosing from heroin or opiates. So we're trying to save lives. So part of it, before I forget to finish my sentence, a big part of it, of course, is therapy. Like I said, it's not just about the medications, but that's a piece of the pie that we're trying to get for our clinic, is to have anybody who's on the Suboxone program getting regular psychotherapy every month, especially if they need it, because there's a lot more than just the pills. And of course, initially people have to come in probably every couple of weeks until they kind of get, every week or every couple of weeks to get regulated, and then just come in every month for their refill. I expect that if somebody starts Suboxone, they might continue it forever, as long as it doesn't turn out to have any terrible side effects. But certainly people can feel free to, get regulated, get a job, get their life together, and maybe taper off after a year or so. But that's not necessarily, my personal approach. Some of this is kind of new, or at least it's new to me, and I think it's a little bit new to the world in general. So it's not like we got decades of experience with it, but the evidence suggests that if you take yourself off Suboxone, it's a lifelong illness, as we said earlier, and you have an increased chance of relapse.
If I took my 8 milligrams this morning and I broke my wrist and went into the ER,
Oh, tricky question.
what would there?
It's an excellent question. I'm still working that out personally. There are various things that you can do. You could take extra Suboxone, and it could definitely treat your pain. So I've had a patient who was having terrible dental abscess, and so she took an extra Suboxone for, a couple of weeks, and then she was in good shape. You could taper somebody off of Suboxone and then give them regular pain medicine while they're in the hospital getting surgery or something, and then put them back on Suboxone at the end. So there's different ways to manage it. It is a little tricky, it's for sure.
But it's not, this 8 milligrams a day, it pretty much wears off in 24 hours.
Ish. No, but you could probably make it a good 36 or plus.
So to have an opiate effective for what it's supposed to do, you have to go off of this for 2 or 3 days.
Yes.
Okay.
But you could probably, it's going to block your opiates a lot, but worst case scenario, you give somebody Percocet and it doesn't work, right? So then you could just keep giving them Percocet until their Suboxone's down enough in their system to where the Percocet kicks in. So I would like to say one thing, Dr. Glyer, which is that because everybody's getting so excited about Suboxone, there's, grants out there to be had to try to help the community hear about it and get on it and blah, blah, blah. So the Howard Emergency Room applied for a grant called the Bridge Grant, which is a way that they've been trying to formalize ways that, because these people, they're not going to come see Dr. Glyer and me. They're going to end up in the ER, and they're in withdrawal, and they feel horrible, and they're like, oh, I fell down a stairwell and I really need something for my back, doc. So, if the ER can pick up these people and has a sensitivity to them, they could hit them with Suboxone right then. Boom, I feel better within half an hour. It is dramatic. You know that part in Pulp Fiction where the guy shoots the, and she's like, ah! It's like that. It's like you give somebody who's miserable, because you have to be miserable to start the Suboxone. That's the one trick with it. You have to be in withdrawal to start it. But you're in withdrawal, you feel miserable, you give somebody Suboxone, and it's like, ah. So it's really very nice that way. So if you catch people in the ER, you give them their Suboxone in the ER, and then you have to get them to somebody. You can't keep going to the ER every day to get your refill. You got to go to see somebody who can prescribe it. So Juliet Lemaire's at the Howard ER applied for this program. She got funding to fund education for the ER doctors and a substance abuse navigator who can work with the patients in the hospital who are addicted to opiates, work with people in the ER, and get them to where they need to go. Marianne. And so she's got a cell phone 24/7. She's on call to try to, communicate between the various providers to get people the care that they need. And so we're really very excited about that piece of it. Okay, Dr. Glyer, you want to say something?
Just to worry about not being able to treat pain. The blockage of some Suboxone can be overcome. You just have to use higher doses of narcotic. So, if someone needs anesthesia, they can get it.
You don't have to wait for 24 hours.
You know, I have a question. There was this girl that went on the Suboxone, and then, you know, she said she used, and they kicked her out of the program. She's back in it again, thankfully, and she's doing great. But I was like, why'd they kick you out? Why didn't they just forgive you and let you come back? You know, like, was it because it was a trial maybe or a beginning?
I mean, it probably depends on the program. We try to go with the 3 strikes rule because realistically, like I said, you know, if people are selling their Suboxone to buy heroin, well, there's worse things than having Suboxone on the street. But realistically, if someone is not ready really to be in recovery yet, so like they repeatedly show up without Suboxone in their urine, well, I mean, really, if you don't show up with Suboxone without Suboxone in your urine one time, you might get disqualified if you're not taking it, especially because it lasts so long. So that might get you out right away. But in general, you know, if you're using meth, if, you know, certainly if you're using marijuana, we don't count that. But if you're using meth or if you're missing your appointments, you know, stuff like that, we try to use a 3 strikes rule because we know that it's so important and it's kind of hard, you know, to get things straight right off the bat. And we want to make it really attractive and accessible, so that's how we do it. And we've been working, you know, a lot with the hospital people about this, you know, trying to communicate and develop ways to try to, you know, address orthopedic patients' problems when they're in the hospital, and we're trying to get them on Suboxone and stuff like that. So we're all, you know, kind of sort of working it out, but we have really good lines of communication, so I feel very hopeful about all of that. Another thing I wanted to say about what you said about getting kicked out of the program is certainly, like, if it seems like somebody isn't really ready, like they're repeatedly coming in intoxicated, you know, stuff like that, then of course, you know, if we do, usually most people I think kind of self-fall out of the program once they get into that bad space, they kind of just don't come back. But we really do feel like, you know, I talked to a heroin addict once who told me that she had, every single time she was in the hospital, people were telling her to quit and advising her to quit. And like, I talked to her like the 20th time she was in the hospital and I told her to quit, and boom, you know, after that she quit. And so certainly it's not like you get one chance and you're done. It's definitely not like that. It's like, you know, okay, maybe not this month, you know, maybe a few months from now. Okay, well maybe next year. Okay, you know, it can happen. Never say die. Never say die. It might not be right now. If you're really in a really bad place, it might not be working out for you. There's got to be some kind of ability to engage and to be compliant. But yes.
Yeah, I was just curious how old this substance is. When was it first made, discovered, whatever? And
Okay, wait.
How long has it been in use generally, and how long has your program been going?
I think it was discovered in the 90s. Late 90s?
Patented in 1979 as a pain medicine, and it wasn't released as a treatment for opiate addiction until the 90s.
Okay. Started using it in the 90s, and it's really just caught on. I would say, you know, the whole tide is turning against the opiate addiction thing, so it really started gaining momentum in the last 5 years, I would say, probably. It started really gaining momentum, and now there's, like I said, a lot of grants out there to try to push it along. Yes, sir. Oh, our program, well, I got my, you have to have a special license to prescribe Suboxone. If you're going to do it for addiction, which doesn't make any sense at all, it should, whatever, but it should be over the counter. But I got my X license almost 2 years ago, I think. But, you know, there are pieces of the puzzle that we're still putting, you know, we're still creating it, we're still making it go. The therapy piece is a really important piece, and we've got that almost dialed in, but not completely. When we have our therapist, we can bring up to them about trying to reach out. Some people are relatively cut off, but definitely the people that I know that show up with a significant other to their first or second appointment seem to have a greater chance of success, and I think that involving those people. But that's a really important, interesting point. A patient she was talking to me about giving this talk today in the office, and she was telling me that she has a friend who quit alcohol and was doing great, and they had a baby, and his wife, you know, really pushed him hard to have a glass of wine to celebrate the birth of their baby, and that's it. He's done. He's done.
Does your program take the medical, does it cost for the medical, what do they the?
Oh, yeah, Medi-Cal is very, very supportive of the whole thing, yes. We also have Medicare. We take Medicare. Suboxone is paid for by Medicare. If somebody had insurance or was uninsured and they didn't have coverage for their medication, we have access to funds. So like you just go to the pharmacy, especially our pharmacy. You go and they give you the medicine and then they bill us and then we get the money from the grant and then we pay the pharmacy. So if there's, they're really aggressively trying to get it out there and they don't want any excuse. The grant that I'm talking about that can get us that access can pay for rides, it can pay for gas, it can pay for other stuff. Yes, ma'am?
Going back to alcohol withdrawal, you said you can die from alcohol withdrawal?
Yes.
Are there situations where you have to go into an inpatient?
Oh, yeah, all the time. All the time.
So you have to be in the hospital and monitored to
All the
learn
time.
to withdraw?
Yes.
All the time? I mean, this happens, it's a
All the
common thing.
You got to go to the ICU. You got to go to the ICU. If you're in alcohol withdrawal, like say, it can either, sometimes like we see it happen you're in the hospital for a different reason. You don't have access to your alcohol. And people are like, why is this person wigging out? And all of a sudden you realize, oh, that's because he has a fifth every night. And it's been 3 days since he had his last fifth. And so, you go straight to the ICU because it's very, very intensive. You have to like stay, it's one-on-one nursing. The nurse has to be right there by the patient's bedside, checking the blood pressure, seeing how they're responding. It's very, very tricky.
I see. So you, as a doctor, when you're seeing an alcoholic, you have to make that judgment about whether or not they need inpatient withdrawal, or if they can just do the benzo taper.
No, the benzo taper might keep them out of the ICU. I mean, usually it'll take the edge off so that they don't go into that severe of withdrawal. That's why we use it, is to try to avoid them having to end up in the hospital or dying. But and also it increases compliance, right? It's not only for that, it's also because it makes you a little bit more comfortable, a little bit more likely to go the distance. But you don't know ahead of time who is going. If somebody has a history of severe DTs, like they were hallucinating when they quit, they had a seizure when they quit, then obviously they're more likely to do that again the next time they try to quit. So you could use that to judge. We don't, but they don't really admit patients for alcohol withdrawal. They won't do it. Like I can't send a patient to the ER and say, hey, listen, he really, really is serious about quitting this time. Can you guys put him in the ICU and taper him off? You can't do that. You have to, it's like, you got to close the barn door after the horse gets out. You have to be in bad DTs to get admitted to the hospital. But usually, if you see your doctor beforehand, you get your benzos, it's a pretty good chance that you won't have severe withdrawal. I remember the first time I was using benzos when I was a medical student, it was like magic, which is why, like I say, sometimes I'm careful about new medications. But I have tons of patients who come to me already on, Klonopin for the last 10 years, and I push everybody to taper down.
Thank you, guys.
Thank you.